Good afternoon. Thank you for joining us today for our Facebook Live presentation on modern knee replacement. Feel free to join in on our conversation today. Post us a question or let us know that you're listening in. We will be answering your questions as we go. Today we have Dr. Jerry Lorio, an orthopedic surgeon here at Arkansas Surgical Hospital. Welcome.
Thank you.
Thank you. So, Dr. Lorio, tell us a little bit about your background and your training.
Yes, I trained at LSU School of Medicine in Shreveport and then did my residency at UAMS under Dr. Nelson, graduated in 1998 and went on to start orthopedic career in Benton, Arkansas.
Okay, so you have a beautiful clinic in Benton. It's on I-30. Tell us a little bit about how long that clinic's been there and kind of what type of patients you see there.
Yes, we opened that clinic in 2012. We had outgrown our prior office and came across this location, changed our name to Arkansas Bone and Joint.
Okay.
We've grown to 4 partners. We have physician assistants and a nice staff. It's really been a great place to practice.
Good. And so what kind of patients do you see there? What procedures, what kind of problems do you see?
Yeah, I'm a general orthopedist with a specialty interest in joint replacement. A lot of my patients are older with fractures, arthritis, but we also, through the emergency room, are going to see broken bones of any kind.
Right.
And injuries to the extremities.
Okay. So today, specifically, we're going to talk about something you're very passionate about. You do a custom knee replacement that's very specific for your patients. So why don't you tell us a little bit about that?
Sure. Every knee has a unique design. Traditional joint replacement surgery for a knee, when I trained, we had different sizes of the implants, but we cut everybody in 5 degrees of valgus, 3 degrees of rotation. That's how you rotate the component and put the tibial implant in the exact rotation, and then we would balance the soft tissues to that. And over time, if you get a severely deformed knee, you have to release everything, and it's wobbly, and then you put in this constrained component, and that always drove me crazy that it couldn't be perfect.
Right.
So I started making some variable cuts at a time when they were doing knees with CT scans and MRIs, trying to customize it. It taught me that that was okay. And studies showed if you're within 3 degrees of the axis, it's okay. So I stayed within those parameters and now have a technique where I can take advantage of that and customize the implant so at the end of the day, the knee is not wobbly.
Okay.
So some knees are real bow-legged, most of them that I see. Some are valgus or knock-kneed. Some have a flexion contracture. Some are hyperextending. And we have an algorithm to customize the cuts across the board so that the knee in the end, we want it straight and able to bend. Usually we can gain 10 degrees of range of motion after surgery than before at the 1-year results.
Wow. So do you use a robot, or what specialized equipment do you do?
No, I'm the anti-robot surgeon. I think it's a glorified saw or mill, but the surgeon has to decide what to do with it. It's not an artificial intelligence that jumps in your knee and does the surgery. That would be dangerous with today's technology. But I think as a surgeon, you got to go through and make the decisions and do the work. So I use something different. This is one of the instruments called the Spider that I collaborated with Biomed and we designed. And it is a sizer, but it determines the rotation of the main cut and the flexion contracture. That little component spins. And when I put it in the knee after the first distal cut, I can dial in exactly where this knee wants to be. I tension the gap to get that number. Traditionally, it's 3 degrees. Ours can be anywhere from 0 to 10 based on the patient's gap, and I think we averaged 4.9 in the study I did years ago. So it's very variable.
Wow.
And that's one of my tricks of the trade. Other guys palpate these epicondyles and determine that axis to get the rotation. My fingers are big. I can never really tell where that is. So the one cut that we start with determines the extension gap, the alignment when the knee is straight, and that varies now from 3 to 7 degrees. The flexion gap is that cut I just showed you. That varies from 0 to 10 degrees. And the third component is matching the rotation of the tibial component. And since the femoral rotation varies, your tibia needs to go and match that. So you can't put it in the same spot every time. The goal is to not have a knee that's real wobbly when they wake up. You want it solid, and that's what we're trying to achieve.
Okay. So are you doing this for a full knee replacement or partial knee replacement?
Yeah, I'm only doing a full knee replacement now. I used to do the partial knee replacements, but they just did not perform as good. The 10-year results were 90%, and over time I felt like I revised every one of them and turned them into a total knee. My total knees did way better than the partial knee, so I abandoned it.
Okay. So it looks like we have a question. Kim wants to know, what other joint replacements do you do?
Sure. I do hip replacements. I'm mainly doing the anterior hip, where we go through the front and don't cut any muscle. You can start walking on it that day. That's really transformed my hip practice. I love that. I do standard shoulder replacements. I do reverse shoulder replacements, and rarely an elbow replacement when that's needed.
Okay. So let's get back to talking about the knee replacement. Just what are some non-surgical treatments that someone might be able to do? Because obviously surgery's not the first step for everybody.
Right, that's the last resort, and many people show up in my office who have been through all the non-operative steps, and we have the surgery talk, but some of them are coming in with their first bout of knee pain, and I have a pain or arthritis pathway, if you will, of simple things that I do. So that'll start with anti-inflammatories, if you're able to take those. We use a simple compressive knee brace, a neoprene brace that keeps the knee warm and compressed. Weight loss, fitness, therapy. I use some of those arthritis gels like Pinsed, cortisone injection, alternative injections, hyaluronic acid. But at some point, patients decide, I don't want to live with this, and then we move on to surgery.
Right. Okay. Well, just a reminder for our viewers, if you have a question, go ahead and submit it. We'll be going probably another 10 or 15 minutes. Get your questions in. We'll get those to Dr. Lorio. But we'll keep talking about the knee replacement, knee pain. So if somebody just continuously is having pain, at what point do you determine they're a good candidate for surgery?
Yeah, first of all, they have to be healthy. If someone has a short life expectancy with end-stage cancer, chronic infection, maybe they're in a nursing home and don't walk, those aren't your ideal candidates. I'm looking for people who could be more active and independent with a better quality of life if I do the surgery.
Okay.
The average patient is about 60 years old. I do some in their 70s and a few in their 80s, but as you get older, you develop more medical problems that could preclude surgery.
Okay. So we have a question from Allie. She asked, how long will I be in the hospital after surgery?
Yes, my average stay is 2 days, but with these techniques for the knee and the hip I just alluded to, a third of the patients are able to go home in 1 day, and a third 3 days. Usually they're closer to 80 with more medical problems. But we really let you get up and move in the day of surgery. I want you to walk because it jumpstarts therapy, and that facilitates passing the therapy goals quicker. If you lay around and don't do anything the first day, you don't get out of the hospital as quickly.
Yeah. So is there any harm in waiting? Say if someone's put off knee replacement for a long time, is there any harm in just continuous waiting?
Yes and no. Yes, in the sense if you wait 10 to 20 years, the deformity can progress where the cuts are more extreme.
Okay.
And instead of doing a posterior stabilized standard spacer, which is this little thing right here, if you go real extreme with the cuts, we go with a constrained if there's the least little bit of wobble in there. And then also you have more health problems and higher risk in your 80s than when you're 60.
Sure, sure.
You know, it's the same general surgery, but there are those issues.
Yeah, okay. So PJ asked, how long will the recovery process last and what will it entail?
Yeah, so surgery is day 0, and we start therapy the first day, and you're home an average of 2 days.
Okay.
But I call over the hump somewhere between 6 weeks and 8 weeks is when you are starting to come off your cane.
Okay.
Most people are on a walker for 2 weeks and on a cane for 4 weeks, but some people will go longer and some quicker. I occasionally have someone that comes into my office on a knee or a hip 2 weeks post-op, no cane,
wow.
no walker,
okay.
no limp.
Wow.
That's rare. I can't tell you who it's going to be,
right.
but it happens.
Okay.
And I think it happens because things are balanced. You're not cutting muscle on a hip, and it's the ideal patient with the ideal pain tolerance, and they just blow through it. But on the other extreme, there's a few patients with low pain tolerance. It takes months, and they may not appear happy to me until that 1-year visit. They're like, you know, I finally got it.
Yeah.
But 6 to 8 weeks is my over-the-hump average.
Okay. So how long are the knee replacements lasting now?
Yeah, 20 years ago, we used to tell everybody 10 years, but now I'd say there's a 95% chance that that'll still be in your body in 20 years.
Wow.
And that's really good for any surgery.
Yeah, that's great. That's great. Looks like Kim may have another question. She'd like to know, how soon do you start therapy after a knee replacement?
Well, certainly that day we've talked about in the hospital. Most of my patients go home, and I do home health, so they're not driving back and forth every day.
Right.
And they're doing therapy and wound care for 2 weeks. Then they see me at that second week for the first post-op visit, and we switch to outpatient therapy and usually do another 3 weeks of that. Most people are done at that point. If I think they're moving slowly or contracted, I'll go longer.
Okay. Here's a loaded question. Monica asked, how much pain will I have following surgery?
Yeah, and that, again, varies with the patient and pain tolerance, but I assure you, I do everything I can to help with that. Depending on where I do the surgery, we're going to offer some type of block, and I'm doing an internal concoction of medication around the capsule to numb up the knee with the longest lasting stuff the hospital will let me use. And then also, I've quit using the tourniquet. I think that's a big source of pain. And it bleeds a little more at first, but patients aren't having that thigh pain and quad weakness as bad as when I had 60-minute tourniquet times.
Right.
And then just trying to meet that patient's need post-op if they're not responding to traditional pain management.
Sure. Well, thank you. We've had a lot of questions today, a lot of good questions. So you brought some information. Do you have something you want to share with us, some data?
Yeah, just some of the variables. The traditional variables 20 years ago, and I'm going to talk in my practice, that when we walk into a knee surgery, you're either going to use a left or right knee. The femur comes in multiple sizes, tibia multiple sizes, the patella component in multiple sizes, and the spacer comes in multiple sizes. At ASH, they actually let us use 1 millimeter difference instead of 2, so that's something unique to Arkansas Surgical Hospital. Sometimes we can translate the knee forward a few millimeters or do a lateral release. The new variables that my technique takes into play is what angle we cut the distal femur at in the transverse plane, and then in this coronal plane, which determines the rotation, what angle we match the tibial rotation. This distal cut, I vary if you have a flexion contracture or a hyperextension deformity. And when you combine all those, that's 1,200 times more specific than a traditional knee.
Wow, wow.
And we've actually expanded upon that. So we're constantly just fine-tuning how to make it just right. And,
yes,
and I
yes.
love that it's never the same.
Yeah, it's so innovative and new and always finding new things. So I think we have another question. Stacy would like to know how she will know when it's time for knee replacement.
Yeah, I think when you as the patient have been through the arthritis treatment pathway, which is designed to put off knee replacement, but at some point that's not working. The cortisone's not lasting as long, or the hyaluronic acid injections, and maybe you're dreading coming in getting that again. The reason we do this is to improve your quality of life, to make you more independent. If you've had to give up your golf game or your hunting or fishing because it's miserable to do those things, you should consider having your knee done.
Yeah, okay. So you mentioned Arkansas Surgical Hospital. You do some of your procedures here. Just
Yes.
Tell us why that's a good fit for you.
Yeah, it was great for me to come up here. I've been here since 2005 when they opened. All the patients here having elective surgery. It's not a hospital with pneumonia and a lot of infections in the hall with general medical problems. It's got a low infection rate, I think, because of that.
Right.
I think they recently got a double
The
five-star
five-star rating. Yes.
I think one of only 2 hospitals in the state for those 2 categories of excellence and something
Quality,
else.
service, all that, yeah.
There you go. But what I like is the staff. They're all hand-picked, patient-friendly, just really make it easy to work here.
Yeah, you don't walk the hall without somebody saying hello to you here. It's a great place to work.
Yes.
Yeah. All right, so it looks like we have another question coming in. Let's see. Kay would like to know if you recommend the machine used at home.
Yeah, I think that's something that I've always used, a continuous passive motion device. We use it in the hospital. It moves your knee when you don't feel like it. I do it 2 hours twice a day for the first 3 weeks after surgery. And it's got to be fit to your knee so that it's comfortable. But for most patients, that's a good experience.
Yeah.
Probably if we didn't use it at all, you would still get some good motion. But there's certain people, I think it really helps get them going when they wouldn't move it.
Okay. Patricia would like to know if you can elaborate on scar tissue after knee replacement.
Yeah, that's different from everybody. There's 2 types of scar tissue. I'm not sure which you're referring to. One is that which forms inside the knee and maybe limits motion. And then your external scar. Some people have bigger external scars than others. Some people have minimal scars, and that may be based on their genetics. If you keep it out of the sun the first year, it tends to fade. If you're outside in the sun all the time, it doesn't.
Yeah.
You can use things like Mederma, a scar cream, or vitamin E, and massage it to keep the skin from sticking to the soft tissues beneath. The internal scar, if you do nothing after surgery from a therapy standpoint, your knee will get scarred and barely move.
Oh, wow.
And that's called arthrofibrosis. Sometimes we actually have to do a manipulation to break through that to get them moving again. But most people won't get that if they work really hard in therapy and push through the pain the first 2 weeks.
Okay, okay. Well, I don't see any more questions coming through, so I guess we're about finished. Thank you for all the questions today. We've had a great response from our viewers, and thank you for joining me today. And if you have any questions, you can go to arksurgicalhospital.com, find out more about our hospital or our physicians here. Thank you. Have a good day.
Thank you.